So,
Welcome everybody, and thank you for joining the webinar. It's great to see so many people. I'm really impressed with actually um, how many people have shown their interest in this. In terms of the webinar, we'll get to introductions in a second, but if just for the sake of everyone being able to follow this easily, if you could please keep your microphone muted. And if you have any questions or comments, please enter these in the chat box, and I will be helping Lucy with this webinar and monitoring the questions. There are two sections in the webinar for Q&A, and we will endeavour to answer as many questions as we can, but it may be that we can't get to all of them. But we will be recording these, so we'll get to those after the webinar if possible. And yeah, you may be invited to repeat your question live if you like, but please don't do so unless we invite you to do so. So we'll move on to introductions now. So I'll let you introduce yourself, Lucy.
thank you, John. Yeah, so most of you probably have heard of me or know of me. I'm Lucy Watts. I am a young person. I'm 26 years old. I live in Essex, and I have a personal health budget. I'm actually on my second personal health budget. Unfortunately, the previous one broke down when a change in needs in my family circumstances happened. But myself and my CCG, as you'll hear in this webinar, have really worked together well to put together a personal health budget that meets my needs and outcomes. And outside of, this kind of webinar, I enjoy, walking my assistant's dog, Molly, who's a big part of my life. I live at home with my mum, and I have a full and active life despite my life-limiting condition. And it'd be great to hear from you, John, a bit about you.
Yeah, so I'm Jon Rey-Hastie. I live in Reading, and I also have a personal health budget and have had since 2014. And I'm also the CEO of a small charity that provides peer support and advocacy for young people and adults living with Duchenne muscular dystrophy, which is what I have as well. And Lucy has asked me just to help out today in terms of monitoring the Q&A, so I'm happy to do that. And yeah, thanks all for coming.
Right, so John, if you want to get started on talking about personal budgets.
So I was just going to kick us off to begin with, just by talking a bit about personal health budgets. I mean, I know you wouldn't be here if you didn't know what the personal health budget was, so I'm not going to kind of teach you to suck eggs, but I kind of want to just emphasize what the key elements of a personal health budget are, and how they actually manifest in kind of real life. What that actually means to people receiving the personal health budget. So yeah, if we could have I can actually do that myself, but yeah, okay. So yeah, I just wanted to go back to the essential definition of a PHP. So personal health budgets are a way of personalising care based around what matters to people and their individual strengths and needs. And they give disabled people and people with long-term conditions more choice, control, and flexibility over their healthcare. So that's their textbook definition. But what does that actually mean? So in terms of the key features of a PHP, and hopefully you'll all be familiar with these, but I think it's always good to kind of go back and refresh the key elements of it. Is that the person with the PHP or their representative should be central in developing their personalised care and support plan and agree who is involved. They should be able to agree the health and wellbeing outcomes they want to achieve, together with the relevant professionals. Should get an upfront indication of how much money is available, which is essential to know how to plan your care and support. And there should be enough money in the budget to meet the health and wellbeing needs and the outcomes agreed in the care and support plan. There should be the option to manage the money either as direct payment, notional budget, third-party budget, or a mix of those approaches. And people should be able to use the money to meet their outcomes in ways and at times that make sense to them. as agreed in their plan. So, again, these are kind of like pretty textbook definitions, but what does that actually mean in real life? So I think for me, and I think Lucy shares these ideas, is that why PHVs are so important is that they can be flexible, creative and innovative. So, it's not about doing things the way things have always been done. It's about thinking creatively and thinking differently and seeing, what can be done. How can care and support be transformed to work better for everyone, really. They provide choice and control, so I think that's essential. When you do have a long-term condition, there's so many things that are out of your control. It's really important to have that control when you can, even just over the little bits in your life that you are able to have some say over is really important. And the personal representative are on an equal footing to the health professional. So it's about changing that relationship between the people like us and the professionals that are supporting us, like yourselves. And it's about kind of working together in a constructive partnership to find the best solution. And most importantly, I think for me, is they work around people's lives. So they allow me to work, they allow me to have a relationship and to live my life. And on the next slide, I just this is really when you get down to it, moving from the textbook definition, this is what a PHV means to me. It means that I was able to start a relationship. It means I was able to get married. It means I can live at home in my own surroundings. It means I can have my pets, and it means I can go away and travel even, and all this with a personal health budget, just by taking an innovative approach. And it just means I can have like a full and meaningful life, and I can feel equal to anyone else, kind of without a condition, really, in society. So it's really important for that reason. So yeah, that was the kind of context. I'm going to now just hand back over to Lucy to kind of take us through the meat of the webinar, so to speak.
Yeah, thank you, John. And I just wanted to say to people, do introduce yourself in the chat function. It'd be great to see who's here and kind of build a community. But what is a PHB for me? What does that mean for me? And one of the biggest things is that I have very complex medical needs. So I'm on total parenteral nutrition, TPN, which is intravenous feeding. I have a double lumen Hickman line. I'm on round-the-clock medications that are intravenous. I have fluids and infusions. My nurses and my carers have to make clinical decisions around, IV fluids, whether to give IV antibiotics. What does that mean for me? Various other forms of medication, a venting gastrostomy or a drainage peg, as some might know it. I have both an ileostomy and a urostomy, or an ileal conduit. So a lot of interventions. I have nebulizers, and if I get really chesty or have a really bad day, I might have some assisted coughs. I also use a wheelchair. I have to be hoisted for my transfers. I need postural support in my wheelchair, and I'm a pressure sore risk. So understandably, for someone who is unable to move independently much themselves, I'm obviously at risk of pressure sores. And I'm also a palliative care patient, so I'm about 10 years beyond my expected prognosis, and I'm living an amazing life that I love. But it is also important to the staff that look after me have the support they need to support a patient who is obviously going to one day perhaps not really have a quality of life and not have what they need, and might need to be a different approach to my care to meet my needs as they change, and eventually that will be end of life care. So I have round the clock care. I have 16 hours a day with an intensive care or highly trained nurse. I then have 8 hours overnight with a carer, and I then have 6 hours of care with a double up carer alongside the nurse for double-handed tasks. And for this, we had to think about what was working, what wasn't working, how we could meet my needs as best as possible. So for me, I had an agency. So as I explained, I had a personal health budget before. I became one of the first in Essex to receive a personal health budget, and that was fantastic. It changed my life at the time, but unfortunately my mum became unwell. And because my mum was filling in a lot of the care and support that, you know, I needed outside of just the PHB, when she was out of the equation, we suddenly had an emergency situation where we put in a 24/7, agency provided directly commissioned package, and myself and my CCG had to do that. There was no chance to put in a personal health budget in that situation. But I didn't always have a very good experience of agency. I really didn't feel like people understood me and my needs. It was a very much one size fits all. I want to be engaged in my care. I want to be involved. I want to have choice and control. And I just didn't have that with an agency. So I went back to the CCG and I said, can I have a personal health budget again? And that involved quite a complex package of care. Obviously, it's not necessarily regular to have nurses on a personal health budget. A lot of tasks can be delegated. Unfortunately, mine can't because of the clinical judgment element of my needs. TPN can now be delegated, but IVs and infusions necessarily can't via a Hickman line. So that's why I have nurses. And we had to really think outside the box. So this came down to my personal health budget plan. What did we want to achieve with that? And my CCG are fantastic. They let me build my own plan. And it was built around what mattered to me. So what was important in Lucy's life? It gave a very clear understanding of me, my life, my goals, my desired outcomes, and what I wanted to achieve, not only with my care, but with my life. It summarised my needs, how we can meet my needs, and the important information that people would need to know, and also a 24 hour by hour breakdown of my needs and the care given to kind of understand what care was needed, how we would meet those needs, whether there was any chance we could change things a little bit. But obviously I've got the same package as I had with an agency, just on a personal health budget. How the package would be managed. So how would I plan to employ my staff? What things would I do? How would I work out the shifts, the hourly rates, and how would I manage my staff? And how would I identify the risks, and how would we mitigate those risks? So there was a big section in my plan about what are the risks of my package? How can we mitigate those risks as far as possible? We then did all the financial costing up of my package, and importantly included training, the DBS, etc., because a training budget was integral to my package. I can't access free training for my staff, although some of it can be accessed for free, as you'll hear later. Most of it needed to be paid. And most importantly of all, it had a solid contingency plan. So we thought through, what would we do if a nurse didn't turn up, if a carer didn't turn up, who would take over that care package? What if my mum wasn't so well and couldn't just pick up the shift? So I'll talk a bit later about how we've managed the contingency plan. And I also have a separate notional budget with the CCG. So we talked long and hard about the contingency funding for my package. How would we manage that? And we decided to have a separate notional budget, which my CCG hold, which has an identified agency who can step in if I can't manage with my regular staff. And I also have some respite funding, 7 days per year, that's also in a notional budget. Now that respite funding is about, yes, if I needed to get away from home for symptom control or something that I needed, but also if my care package broke down, I could go into the young adult hospice at home service and we could sort out the package before I came home. And to think about costs, so it's not about cost. PHBs are not about cost saving. They never should be about cost saving. But what's important to think about is, can we get the most for the money we're spending? And as you can see on this slide, there's a total saving annually between an agency and a personal health budget of £101,000. And that's a fantastic saving. But what we've also got is the best possible care for my needs, and we're saving money. We've got the best cost efficiency, we're spending the money in the right way, we're meeting my goals and outcomes, and we're cutting the cost from an agency in the process. And why wouldn't we want to look at personal health budgets if we can achieve that cost saving and give people more choice, more control, more flexibility? That is so important to me, it's so important to patients, and it's so important to CCGs to make sure that every penny they spend of their money is spent in the right way, the most efficient way, and that achieves the best outcomes for the patients. I'd like to hear from Nancy from my CCG. And Nancy, if you unmute yourself, would you be able to talk a little bit about your experiences with the process with us?
Hi, everybody. My name is Nancy Mizondo, as you can see, and I'm the clinical lead for Castle Point and Rochford CCG. So I'll just talk briefly about my involvement in Lucy's personal health budget phase 2. I think, we had learned lessons from phase one that, there were teething problems and there were some things that didn't particularly go well. So I think right from the outset, when, I was involved in meetings with Lucy, we set clear goals and outcomes. And if you've met Lucy, you'll know that Lucy, she knows what she wants, and I think it was good working with her in that way, because she was quite clear and I was clear as well, and it helped me as well in terms of supporting her with her personal health budget. And one of the things that we kind of did through that phase two journey was working together with Lucy. So not me dictating to her, but actually working together. So, and to be fair, I think Lucy did most of the work in phase two. And, I was just, kind of helping to ensure that from a CCG perspective, we looked at the risks and, obviously the governance, as well as ensuring that, everything that needed to be put in place was there. And also working together with, people who were the multidisciplinary team, like, we looked at, pressure management and, equipment. And so we got the tissue viability nurses involved, as well as the occupational therapists involved in ensuring that, we were providing the best equipment that would help Lucy in her journey. And I think also thinking outside the box, and I think Lucy mentioned that, was quite key in phase two, because I think sometimes we just do things because they're standard and they're routine. And one of the things that was identified in Lucy's support plan was aromatherapy massage. So initially when I looked at it, I was thinking, what is this? But, then Lucy went on to explain that, this would help in terms of, loosening, tightening muscles or, contracting muscles, and also would help in terms of pain and pain management, which is a big issue for Lucy. So we were able to build that in within the support plan and, get nurses trained in aromatherapy massage, so that Lucy wouldn't have to either go and source that out from private providers, and, just kind of, ensuring that, she wouldn't have to book, didn't have to have people coming in, but, these were nurses who were within her support plan, who within her budget, who would provide care, as well as providing that, needed aromatherapy massage. So I think in a nutshell, if there's anything to take from Lucy's personal health budget phase two, was, I think, being clear in terms of goals and outcomes, and also working together, because Lucy provided a wealth of knowledge to not just to me only, but I think to people within the team. And that has helped us to kind of be where we are in terms of phase two with Lucy's personal health budget. And I think that's all from me for now.
Thank you, Nancy. That's great. I really appreciate you coming on. And I wanted people to hear from the CCG, because I didn't want it all to come from me. I wanted them to hear that actually it's worked well for both sides, and that's very important to both of us, to get the best for the CCG, but also to get the best for me out of my care. So in terms of the kind of employment side of the PHB, now my PAs I obviously already am employing. That was phase one. The night carers and the double up carers went over in phase one, and that was well established. So I had my carers, and that was, managing that myself. And then we moved over to phase two, which was the nursing side of the package. And then we had to think about a lot of different elements of the package that weren't so important when it was just carers. As we're all very well versed in employing carers. I've employed carers since 2009 on various direct payments, integrated budgets and so on. But I had to think about, how am I going to manage nurses? There's a lot more red tape. There's a lot more things to factor in. There's the NMC registration. There's making sure their PIN stays valid. There's making sure that they've got the competency and the skills, that they're comfortable, and that everything is done in line with their code of conduct. Because we all know nurses have their own code of conduct. So I needed to make sure that my design of my package married up with the that what the nurses needed to do as their code of conduct, what was important to them in their role. And I did talk to a lot of different people. I talked to some lawyers, I talked to various nurses, I talked to my colleagues. I am very well connected, and I'm lucky because I was able to draw on a lot of knowledge to build this together. There's some people here from St Francis Hospice that have provided some great support to me as well. And to put this together, we need to think about, what can we do to support the nurses? What can we do to manage the PHB in the best way possible? One of those things was I needed a pay rate that would meet the needs of my staff, but would also be attractive. We know NHS agenda for change, you know what the rates are, but the problem is when you're in the communities, it's a very different setup, and I have to compete with agencies. So I need to be able to give a rate that not, it won't meet the same cost as an agency, but it was competitive enough to draw staff to the package, that it met the needs, and that it rewarded them for the amount of risk they're taking. Although I'm a very activated patient, I can help my staff in many ways. There's a big thing with a lot of staff I talk to about they wouldn't want to take on my package because the level of risk they would take on their own. They wouldn't just be able to call in the nurse from the next ward, or and although there's the hospice and there's my team in London and there's the local hospital, they could always draw on other support services, the district nurses, but they were genuinely on their own on a day-to-day basis. So I needed to come up with a rate that would work for them. And so myself and the CCG went back and forth with the rates, and I found the British Nursing Association rates, and that kind of gave an indication of funding in the community for non-NHS care and what the kind of rates were. So I worked out from that, a good rate that wasn't asking too much, but also was enough to manage my staff. And I get £30 an hour on a weekday and 35 on a weekend, but obviously within that funding, I have to allow for national insurance, I have to allow for pension and so on and so forth. So that, obviously that £30 comes down to £26.50 on a weekday daytime, £27.50 on a weekday out of hours, a Saturday rate of 28, a Sunday rate of 30, and a bank holiday rate of 35. And I've managed to recruit staff who are very happy with that pay rate. It's very attractive to people. It's more than they get elsewhere on the NHS in the community. So I've not struggled to recruit, and I'll come a bit onto recruitment in a minute. But I had to think about how am I going to manage the nurses? And one of the things that was really, really important to me was to have flexibility. I could not guarantee my nurses had shifts, regular shifts, set times, set hours, because due to my work, I might be in London from 6 o'clock in the morning one day until 7 o'clock at night. The next day I would go out in the evening. I needed that flexibility between me and my staff, and I needed to find a way that gave them contracted rights and gave them support, but also met that need for flexibility. And I decided on having a 0 hours contract for my staff. It gives them the flexibility to pick their own shifts, to send in their availability a month at a time, and we work out the shifts based on that, based on my needs, based on their needs and their availability. And that works quite well both ways, because my nurses also get the flexibility that they want, and that I get the flexibility that I need. And I also looked for nurses that already had another job. So perhaps nurses that worked in the NHS, worked for an agency, worked in another situation. And one of my nurses used to work in a care home. Thinking about having people that weren't completely dependent on me and my package, so that if my package didn't exist, I went into hospital or anything happened, that my nurses could survive and I wouldn't lose my staff. And that was so important to me, to make sure that my nurses were protected. And the other thing I had to think about is the working time regulations. Was I abiding by the limit of 48 hours on average work a week? And my nurses do shifts of either 8 hours or a whole 16-hour shift, if that's what they decide, with a lot of downtime. They get a rest break every 6 hours for 30 minutes. They get a lot of support, but some of the nurses would rather work one long shift rather than a short shift. They get the choice. It's never enforced, and it just works out between me and my staff what works for them. But they have to have at least 11 hours off consecutive between one shift and the next. And if they do a 16-hour shift one day, they cannot then do a long shift the next day, and they can't be there the next morning. They would have to do a late shift the next day. Thinking about all these creative aspects. They have a nest pension, so I couldn't carry over the NHS pension, unfortunately. It just wasn't accessible, but obviously they've got a nest pension and we pay into that. They get holiday, 5.6 weeks pro rata based on their hours, and they get statutory sick pay as long as they work at least one 8-hour shift per week. So as long as they hit that minimum earning limit, if they work at least one 8-hour shift per week, so as long as they've worked on average 8 hours a week, they will qualify for statutory sick pay. And I also tried to give retainer pay. Let's just say I went into hospital and my staff were kind of waiting at home. Can I pay them a small retainer fee for the shifts they were missing? It's not a contractual right, but it's something I've explored. If it's possible, it's something I would like to do, but I don't know what's going to happen, or whether my staff could even come and look after me in hospital if we got that contractual basis with the hospital. In terms of recruitment, that was quite difficult initially, trying to find out places to recruit staff. So I can't access NHS jobs, I can't access track. I did try, and I investigated it really well, but it wasn't something that was possible. So I looked at other sources of advertising. So very successful for me was Indeed. So I got a lot of responses from Indeed. I also got a lot of responses from social media. So I set up a dedicated website about my personal health budget. I set up a Facebook page, and I made a video advert for people to see and shared that far and wide on social media. And that also brought in some really lovely staff. My staff are all very different. They come from very different backgrounds, and we had to think about, how we can meet their needs in the best way possible. And I'll come to training a bit later. In terms of their contract, they also have a 6-month probationary period. Before the end of that 6 months, they have an appraisal. So they get the chance to talk to me about their role, how they feel. I get to talk to them about how I feel about things. But crucial is that sharing both ways of knowledge. So I can appraise them, but they can also appraise me in return of how I am as an employer. If there's any issues, thinking about, can I improve as an employer? And in terms of the band of the nurses, now we can teach them all the skills they need to know. I didn't need people that had years of experience in TPN and IVs. We can teach them the clinical skills, but we couldn't teach them to be the right person. So band 5, band 6, another band, it didn't really matter to me. As long as they were a registered nurse, they had that PIN, and they could meet my needs and were willing to learn. And I'm also really keen on supporting my nurses with their revalidation to make sure their PIN stays valid, and I can support and give evidence for that. And the contract also states that it's their responsibility to manage their PIN, so they have to make sure their PIN stays valid. That is their responsibility. If their PIN was to run out and they didn't tell me, that could be grounds for dismissal, but hopefully we would work together. They would notify me of that, and we would take them off the package for a little while until they're revalidated. So I thought we'd have like a Q&A bit now, which Jon will help me moderate. And if anyone's got any questions they'd like to ask, I'll come on to training and CPD a bit in the next bit. But if anyone's got any questions, it'd be great to hear from you, what you think, and what works for you. So is there any questions in particular, Jon?
Yeah, so we've had a few, and do everyone please just keep typing the questions as we go along, and we'll try and get around to them. So there was a question specifically around the employment costs, and particularly around the pensions, and about whether or not you contribute to pensions. So maybe you want to explain what you do need to contribute towards pensions.
So the pension contributions, I mean, my mind's gone blank about the percentage. I think it's now
3%.
3%, yep, and it goes up the next couple of years. So we contribute to the pensions. My staff have the option, so they always have the option to opt out of their pension. I always encourage them to go for their pension, but obviously I contribute my percentage, they contribute their percentage, and that goes into the nest pension. So that's how we manage that. Again, I have to give people the option to opt out, but I really do encourage them to take that pension. And it's just safeguarding their futures as well. Really, it's important for my staff. I hope this comes across that my staff matter a great deal to me. Anything else in particular, Jon?
Yeah, that's great. So just around insurance, and whether you needed a specific insurance policy in place to cover the nurses, or whether you could do a standard home employment like PA policy. So
I spoke in great detail. I'm with Fish, and I spoke in great detail with the underwriters, with the team, with their legal firm, and actually they can cover the nurse on my PHP. They can now cover nurses. So that is one thing. We also got to remember that my nurses naturally have insurance through their PIN, so they've got indemnity in that sense as well. But to protect myself as an employer, they are covered under my insurance. There was no alterations to the policy that I needed, as long as I just notified them that they were nurses and not carers, and they were very happy with that. But it's worth exploring it with your insurance provider, or the insurance provider that your patients are going to use, to make sure that it will always be covered for every person that's that you're working with.
Yeah.
Anything else, Jon?
Great. Just a question that's just come up about how you manage all the admin. So all the managing the rotors, the timesheets, the payroll, and all of that.
So interestingly, I did look at different platforms about like Monday and Asana and things like this that you can use, and I could buy in that service. But actually what's been most useful for me is just keeping everything documented in spreadsheets. Now, in terms of shifts, I will try and give my nurses as close to regular shifts as I can. So we have a dummy rota, so to speak. So they genuinely just send in their availability a month at a time. Usually they will work the same shifts. There'll be some swaps. But with that, it's just writing everything down. It's keeping spreadsheets is one of the most useful things, because you can do calculations and percentages in that. So it can tell you how many hours someone's worked. It's worth investing in. I did some online training and webinars about spreadsheets, because if you can keep everything in a spreadsheet, the documentation is easy to follow. You can do the calculations. It can calculate things for you. That has been really useful for me, to use those platforms, to use the techniques I've got. I'm quite good at admin, I will say that. It's not the same as for everybody else, but being organised is one of the most important things. I've got to stay on top. And also my mum, although obviously she's not managing my package, she does support me with my admin. And likewise, the nurses fill in their own timesheets, and then I check them and send them off. So it's thinking about how can you use the staff, use the people around you to manage that package as best as possible. It's been bringing all those resources.
I always say that managing a PHP on a direct payment, it's kind of like a part-time job, isn't it? Really, in terms of all that kind of admin stuff, and then you have to, try and have a life on top of that.
Yeah.
So I'm just kind of trying to focus on the more specific questions around this, and then maybe we'll get on to some of the more general questions.
Yeah.
A question from Joey was, when developing your care plan, who was involved, and how often do the CCG support you in reviewing this?
So with a personal health budget, obviously you have, when you've signed off the package, you have the 3-month review and you have annual reviews. But what the CCG and I did that was very helpful is I would build the care plan, I'd email it over, and so although we didn't necessarily always have meetings, we met probably every 2 months face to face, but we also worked remotely together, sending things across, sending letters, sending emails, sending things that we could kind of go back and forth with. Other people involved in my PHP was my hospice nurse. So the hospice that support me were very involved. I had a support from a friend of a friend who's a trained advocate. Now, I'm very good at advocating for myself and I work as an advocate, but it was just helpful to have someone else there to reiterate my perspective. So I had my advocate as well. Obviously had the CCG and others involved. My team were a little bit involved, so they would provide information if we needed it. We had the OT, we had the tissue viability nurse. So there was a lot of people that weren't necessarily involved at every meeting, at every section, but they dipped in and out depending on what we needed them for. So that worked out quite well for us.
Great. And there was a question just around how many staff that you have to cover your care needs, and also like thinking about holidays and how much holiday people get and how you cover that.
So I have 5 nurses at the moment, and I can't give them enough shifts, so they're all kind of fighting for the shifts, which is quite difficult. But I'm starting to, obviously because of COVID and everything like that, I haven't pushed with the recruitment because we've kept my team small, obviously purposefully, and that's kind of been how we've managed that at the moment. But I will be recruiting a bank team, so very important to me is to have my regular staff and then a team of bank staff. But I also then have an agency who I can call upon. So I didn't mention it, but my contingency plan for my package would be, let's say someone calls in sick, can the regular staff cover it? Yes or no? If they can't, can the bank staff cover it? Yes or no? If they can't, can the agency backup cover it? Yes or no? And as a fourth option, my mum, who is trained in all my needs, would step in to that nurse's role. So we've got a lot of thought out contingencies to allow for making sure that everything would be covered. Unfortunately, my mum can step in at the last minute, which is very important. But I'm looking to recruit, so I've got my 5 regular nurses, and I'll be looking to recruit maybe 4 or 5 bank staff, and that's going to start up again soon after COVID, everything that's happened this year. I'm going to start recruiting again for my bank staff, and obviously they will again be on a 0 hours contract, but they won't have any regular shifts. They will just do the odd shift to keep their skills up. And likewise, I'll talk about the training in a minute, but that's another important element.
And just a question about costs. This was more coming from a patient perspective in terms of how you kind of justify the extra costs, and obviously in some ways you're going to be saving money, in some ways it might be a little bit more, and you need to kind of look at the balance. But I just wonder how you justify the kind of the cost that you mentioned, say the pay rate being being a little bit more in order to attract people. I just wonder how you kind of justified that and what discussions you needed to have around that.
So with the CCG, we had long conversations about, what was available, what we could do, but we talked back and forth quite a lot about, what is a reasonable rate for the NHS, but then how can I compete? So I went away and I did my research. I contacted agencies, what agencies would pay their staff for a similar package. I looked at, private funders. I looked at adverts on various different platforms for similar roles, so TPN nurses, things like that. So I got a body of evidence to show that I would not be able to recruit at the rate I was being offered. And the CCG were very good. They said to me, well, if you can evidence, why we have to, have that increased rate. So it's all about the evidence and documenting, why that is necessary. And then we can obviously talk about, what that was. And we came to a rate that worked for the both of us, that allowed for those additional costs such as national insurance. It really was a partnership approach. It was the CCG being willing to learn, to hear new things, to see different evidence, but it was about documenting why you're asking what you're asking for. If you can evidence why it's necessary, you are more likely, if not completely likely, to get that funded. But it is all in that crucial evidence and justifying it, and that's an awful thing to say, but you need to make sure that the CCG are getting a good rate for what you're asking for, but also that it meets your needs in the best way possible, and you can evidence why an increased rate is necessary for your package, or increased training funding, why you have to use a certain training provider right over another. It's thinking about this, and it's also thinking about being creative in how you manage the funds, and are there ways that you can save money elsewhere or use things more efficiently. As I said, it's not about cost saving. It shouldn't be about cost, but it should be about meeting your needs and getting the most efficiency for that cost that you're paying out, or the CCG are paying out. And I know the question says about cheaper to put you in a care home. I mean, we have had that discussion, but obviously we got an agency involved, and because I could evidence that actually going onto a PHB not only saved the money, but actually it met my needs better. The agency just wasn't working. I wasn't getting on very well. And it's all about kind of looking at the different options, exploring those costs and seeing what you can do. So some PHBs are more expensive than the indicative budget. Some PHBs are more expensive than a nursing home. But does that meet your needs in the best way possible? And having those conversations with your CCG.
Yeah, I'd agree with that. If you put someone in a care home and it really isn't meeting their needs, then you're going to cause all sorts of extra additional problems that are going to result in extra costs. So it's a false economy really, to kind of look at it that way. And it's also it's a morality issue, isn't it, as well? Just in terms of what kind of lives do we want people to have. Yeah. So I think we've got time for one more question. Yep. Just a quick question about how long this all took to set up, and from the start of getting your PHB to actually having this in place, how long did that take?
So this was quite an interesting thing. So the night carer phase 1, which is obviously not what we're dealing with today, but that took about 2.5 years to set up. We had lots of setbacks, we had lots of problems. And I think, like Nancy said when she spoke, we learnt a lot from doing the night carer and the PA side when we came to the nurse side. From the nurse side, it actually took, from actually working on the plan to signing off the package, was about 9 months. Now that sounds a lot, but when you consider the amount of detail we had to go into, that was very quick compared to 2.5 years for a basic carer package. But it was also about dotting every I, crossing every T, getting the OT assessment, getting the tissue viability assessment, looking at other ways of meeting my needs, like Nancy said with the aromatherapy massage, getting the evidence for that, talking about equipment, the bed. There was a lot of things we had to think about. We were looking holistically, and that's what PHBs are about. You have to look at the whole, thinking about are there other ways of meeting needs. So, having the right equipment could present you needing more care returning time, because you could have a bed that could turn you yourself, or a piece of equipment that could turn you, thinking about all those avenues. So 9 months or less than 9 months to build that start to finish, and then obviously it took a little while to then sign it, to get it started, which was a couple of months, but then that's been absolutely fine since. So it was just, what took so long was the complexity, and what took so long was making sure we had everything right and that we had met every need and we thought of every problem.
That's great, thank you. I think we need to move on to the next section, and then we'll take some more questions at the end.
So I also want to talk about the clinical governance of the package and the training of the staff, because obviously that's another important aspect that I had to consider was, I needed someone to take oversight of the package in a clinical way. I didn't have a professional locally that could provide that service, so I wasn't, for children, their children's community nurse might take that role, or there might be a local service. For me, there was no service that could meet that need. So with the CCG, we worked out a way of how we could, make sure that clinical judgment, clinical oversight, clinical governance was managed. And with that, I had agreed that one of my old hospice nurses was going to provide that training and provide that support. But then she unfortunately stepped down from the package quite late in the day. But I was fortunate that one of the nurses I'd taken on for the package was a TPN home care nurse. So I said to her, and I said, have you got experience of training? Have you got experience of managing other staff? And she said, yes. So I said to the nurse, I said, well, would you be willing to take a more senior role on my package? So she would get her regular rate for doing the shifts that she would work, but she would also get an enhanced rate for doing additional care above. So if she was doing training, if she was doing, any clinical governance tasks, she would get paid a higher rate to do that role. And she has oversight of, the MAR sheet, she has oversight of the care records, she has oversight of the fluid charts. She can also liaise with me medically if I needed to, so if I was poorly, she could contact the CCG on my behalf. She could manage that. She's also there for the staff, so if the staff have got a query or a question or are unsure, they can phone her and say, what do we do about this, what's your opinion, and she will give that advice. The good thing about her working with me regularly is she keeps her hand in, so she knows me very well, she knows my needs, she works with me regularly, but she's also then there for the other staff. She also then delivers the training in my TPN, central lines and IVs. So she does some of that training and she monitors the nurses' competency. So she allows the staff to build the competency slowly and provide them with the support they need and the ongoing support and training. And also we use shadow shifts where staff are new, so we try and get the staff to shadow the senior nurse if possible on a shadow shift so she can teach them how to care for me. In terms of training, so we had to think about the training costs and how we would manage that and how we would look at the different ways of meeting training needs and finding, and I know a lot of CCGs will appreciate this, finding training for personal health budgets, especially for complex needs, is extremely difficult. And I had a real tough time trying to find someone who could provide the TPN, central line and IV training. And as I said, my old hospice nurse was going to step in and provide that role, but then she couldn't. So obviously my senior nurse now manages that for me. And she can have up to 3 hours per nurse per year to train them. So that, I probably wouldn't have, 3 hours per nurse per year, but she can have up to that. So she could come in and do competency checks. She could come in and do more training. She could come in and support someone. She can check their competencies annually. And obviously when they first start, she can deliver the full training when the start person is new on the package. And she can manage that herself quite well. We work together. She involves me in the training, so we work together on that. I witness the training. And then in terms of the competencies, she signs them off competent to have done the training and then competent in the task, moving forwards. And I then countersign that competency as well as the employer to say I am happy. I've managed to source online mandatory training, so I use a provider called Pro Trainings, but also Skills for Health or another provider, looking at manual handling, basic life support, things like that the nurses probably will already have. Again, they work elsewhere, they don't just work for me, so their other jobs keep up their mandatory training. But if they needed to have mandatory training with me, I can obviously commission that support. In terms of stoma care training, the local stoma nurses come in and teach my staff, so I can get them to come in for the day and teach everyone about stomas, diversions, things like that, and they can get that training for free. That's a freely provided, so they provide that for both my nurses and my carers. There's specialist training in holistic, person-centred and palliative care provided by St Francis Hospice. I think they've mentioned it in the chat. We had a long discussion. I asked them if they were able to provide a bespoke package of training for my staff, looking at the palliative side, the person-centred nurse, the symptom control, the assessing, and also their own personal skills, keeping those up and giving them, the tools to learn and grow and develop and feel confident in their role, but also as I reach the end of my life, because this PHB is about the now, it's about the keeping me alive so I can work and go out and do things, but it's also about as I deteriorate, can my staff continue to support me? So we have this package of training, and the hospice, we haven't started it yet, but the hospice will provide a day's training for my nurses and my carers to go to the hospice or do it online, and we'll go through all the different aspects. And we discussed also that there might be sections of the training where the staff don't want me there, so I need to be prepared to go out so the staff can ask those awkward questions they might want to ask in front of me. And then I also have staff get-togethers, so the staff can come together as a group for additional training, for social and other opportunities, but also for CPD. And I'm always looking for other ways of meeting needs, other ways of sourcing training. So I'm linking up with nursing bursary charities, I'm linking up with training, I'm linking up with webinars. I'm always trying to see how I can develop my staff, because I want my staff to gain from working for me. And in terms of the cost, so my upfront cost for training the nurses when the package started was £2,700. So that covered the cost of those training those nurses initially. And the ongoing training is £2,000 a year. Now, I can personalise that depending on what I need. It won't be training 10 nurses per year in TPM, because I'm hoping there'll be a continuity. It's thinking about that £2,000, how can I use that most effectively to meet my needs, and looking at free training, looking at other options to meet my needs. And again, I want to develop my staff. I want to give them skills and tools that they can use elsewhere. And that was another thing that was attractive to people, was the chance to build their skills. A lot of the nurses said at interview they were very interested in the chance to build skills and learn more about complex needs and different aspects of needs and TPN and IVs and central life. They were very much interested in learning all of that. And it's thinking about, attracting staff. What can I use to attract staff? They can build skills. I can give them competitive pay rate. I can support them, and they can be the nurse they want to be. That's what I very much said to my staff. You can be the nurse you want to be. You can spend time with me. You can, talk to me, interact with me. When you're on a hospital ward, you haven't got time to sit with your patients for 4 hours and have a chat. My nurses can. We can support each other. We can just talk and chat, and they get to do the nursing that they came into nursing for. And I don't know if anyone's got any kind of questions about, training and stuff like that, if you start putting those in the box. But the other thing that Nancy mentioned was the aromatherapy massage training. Now, that was a unique request, but as Nancy said, it was about pain management, stiff muscles. It was about another way of managing my needs without resorting to increasing opioids and muscle relaxants. And how can we meet those needs holistically? And my nurses can be trained in aromatherapy massage. I can have it 8 times a day if I want, because the nurse is trained. I don't have to have a 1 session a week that I have to pay privately. I can just have it when I need it. And that was another thing that my nurses could develop, was another skill they could develop, a way they could meet my needs better. And that, again, supports me holistically to meet my entire needs as a person. And that's what the CCG have been very good at, is looking at Lucy. What does Lucy need? Not what does the CCG provide, but what does Lucy need, and how can we meet Lucy's needs in the best way possible? So I think if we head over to the second Q&A, because I think we're getting quite close to time. If John, do you want to kind of summarise first, and then we'll kind of do the questions, or should we do the questions first and then summarise? If you do the questions first.
Do the questions first, yeah. So, we haven't had any specific questions about the training yet, although people still can type those in. But we did have a couple of questions that had come up. So, one of the questions was how many hours your senior nurse does as part of your support, and also whether you're able to share the rate of pay that they actually get.
Yes, so we pay the nurse £40 an hour for the additional tasks, and again that might be very different. So she'll get £40 an hour to do the training. She will get additional pay to look over the care notes and any queries, and so she's quite flexible. So she will kind of do a lot of the admin when she's here on shift, which helps because obviously she's already here. So I can just pay her an increased rate for an hour while she's on shift, and she can do that hour of admin and looking through the notes. So that's one way we manage that. But again, she might come in for 3 hours on a Saturday to do a bit of work with me or to go through things. One of the things she said, I didn't record the batch numbers of my TPN and my IV fluids, and she said, well, if you record it, and if you get a problem, that you can think. And it was all these kind of little things that she was adding into my care package, and obviously we recompense her for all those hours. So she might not get extra pay for a month, and then 1 month do 5 extra hours or 6 extra hours. It just depends on what the needs are and what it depends. And again, because she's working here regularly, she can kind of do the extra stuff while she's already here.
Okay, and another question is how you found out exactly how much you were allocated for training in your PhD. So maybe just talk about the budget setting process and how you were involved with that.
So I had an upfront indication for my PhD, which was the cost of the agency. So what they were paying for the agency that were providing my care, that was our kind of upfront indication, because that was the only other way we could meet my needs in the community. So that gave us a very good indicative budget to work from. Now, my phase 1 with the carers, I did have a set indicative budget that was separate from the agency. With the nurses, because it was quite new, the cost was compared to the agency package that I was receiving. And with the training budget, they weren't sure what training I needed, so they didn't give me an upfront indication of the training. I kind of went away and sourced the training that I could find and then presented that to them to be agreed. So there wasn't necessarily, oh, you can have £5,000 for training. It was, if you go away and tell us what training you need, talk to your team, talk to your hospice nurse, talk to providers, then come back with those costs. We can work together to decide, a reasonable package of training funding. So again, the upfront indication was the nursing package. We didn't have specifics within that nursing package. So obviously the package for the agency was the direct care of nurses, whereas PHB would have the direct care of nurses and other costs. But that's how we kind of worked it. And it was what I really liked about the CCG. It was never about money. It was always about how can we use the money most efficiently. So what have we got? What are we spending? What are we doing? How can we use that money more effectively? And the cost savings came because we thought outside the box, because we worked together. And that partnership, that relationship, that building that level playing field was so important, because I could submit things to them. Then my hospice, my CHC nurse would go to the panel and discuss what I'd presented and then get that agreed. So it was a very much collaborative process. So there wasn't an upfront indication for the training, but we worked together to build a good cost for the training that would allow me to train my staff, but was also not asking for an extortionate amount of training. And down to like manual handling, I was looking at personalised manual handling training, and it was going to cost £1,000 for a day's training. And it was like, actually, do I need to pay £1,000 every time I get a new staff member to train them in manual handling, or can I use another service? So again, I went away and found another service. Yeah. Anything else, John?
Yeah. So we had a question around just your mum in terms of as an informal carer. Was she included in the conversation, and but was her own health and well-being reviewed as well?
So the interesting thing about this was, because my mum was ill in 2015, my mum was not actually part of the conversations. Although I talked to my mum, I kept her out of the process deliberately because she was recovering. So although my mum's needs were considered, and my mum wants to be one of my staff members, she's paid on my package as a PA, but I was very adamant that my mum should be able to choose to care for me and not have to care for me. And the CCG were very good. They didn't ever pressure me to say that your mum has to do this or your mum has to do that, or any kind of pressure. My mum was out of the equation. She was poorly. She was recovering. She spent 6 weeks unconscious in hospital. She was then recovering for a long time. She had a brain hemorrhage and a stroke. So my mum was really poorly. So she couldn't be part of that process. And what we ended up doing was building a package that meets my needs, whether or not my mum can provide any care. Because equally as much, if my mum had a seizure tomorrow, she has epilepsy, it's very well controlled, but if she had a seizure tomorrow, I need a package that would work even if she wasn't in the equation. But I can still pay her as a staff member, as and when I choose, if that meets my needs best. But again, there's no pressure, and like any employee, she's entitled to the same employment rights as my other PAs. She gets entitled to breaks, she's entitled to support for herself. And thinking about my mum in a different way, my mum is not just a person that can pick up where everyone leaves off. She will do that if she has to, but it's thinking about her rights and her needs. And her right is to be able to step away for a week and say, I'm going on holiday.
Oh, cool. So just a question around kind of, I don't know, how you figured this all out, how you kind of, you went from, probably starting off not knowing that much to having to be the expert in this, and whether or not you used a support broker to help you at all.
So a lot of what I've been able to do has come through my work. So I work as a PHB broker. Funnily enough, I work for some CCGs as a broker. I do independent advocacy. I work with charities. I work with NHS England. There are a lot of things that gave me a lot of skills and a lot of knowledge But the most useful thing was the contacts. I have a lot of people I can go to. I've got, a lawyer that I know that I could ask her legal questions. I've got nurses that I could go to, a whole range of nurses and ask their opinion. I could go to St Francis Hospice and ask their opinion. I was able to utilise the resource, and that's what's been really useful. I haven't known everything off the bat, but I've had access to the resources to know what to do. And the CCG took a bit of a risk, allowing me the license to kind of do whatever I could to find out the information I need. But that's what met my needs. But I'm just lucky, privileged, whatever you want to say, that I am well connected. I have a lot of work, work that people I work with. I have a lot of education. I was able to access those support. I don't think if I wasn't as activated as a patient, if I wasn't so involved, I would have known that information. And that's why I kind of want to share it. I want to empower CCGs to be able to offer more complex care packages, to offer more support for their patients, because if the CCGs are empowered, so are their patients.
Yeah. So I think we're probably coming to the end of the questions that we can answer for the moment. I think we've covered most of them, but I think Lucy, you're certainly happy for people to get in touch with further questions, aren't you?
Yes, so if anyone wants to contact me, it's lucy@lucy-watts.co.uk. If you go on www.lucy-watts.co.uk, you can find me, or Google me, you'll be able to find my information. As I said, I'm a PHB broker, so I help build packages for CCGs. I work with a lot of CCGs on that, trying to share the knowledge, trying to support people, but I'm always an email or a phone call away. I've gone to some CCGs and delivered some training if they want that. So if there's anything I can do to help any of you, any contact, any support, please do get in touch. I want to share the learning. If anyone would be interested in seeing the clinical documents that I have for my staff, or the contract for my staff, or anything like that, you can always get in touch and just let me know. But thank you for joining us. It's been really great to have you here. And do you want to sum up for us, Jon?
Yeah, so I think the key message is to kind of take away from what you've been talking about is just that this is possible and it can be done, and to not be kind of scared off by what might be involved. I mean, clearly it's not been an easy process for you. It's taken time. You had to do a lot of research. You've had to do a lot of the work yourself, and I think that's that's certainly been challenging. But you've got the result that you want, and I think clearly setting out why this was important to you. It's so that things can fit around your life, so that you can continue to have the life that you want to have, and the health management of your health needs kind of fits around that. And I think it's all really about fitting around you and kind of making it work for you in your life. This is a different way of doing things, but that's what PHVs are all about. It's about being innovative. It's about taking some managed risks, but you have been in control of the process the whole way through, and your life has never been put in danger during this process. So I think it's about being open to being a bit creative, I would say. And, did you have any kind of last points you wanted to make?
I just wanted to say, that because I've got the right care in place, we've thought creatively, we've looked at the options, we've done things that are a bit innovative, we've looked outside the box, we've done things outside the status quo, we've achieved the best possible outcomes for me. And it's thinking about what can we do to think that little bit outside the box to achieve the best outcomes for patients. I can go to work, I can earn my own living, I can go on holiday, I can go to a festival every year, I can do all the things I want to because I've got the right care. And I think the step with PHBs is empowering patients to take control, and that's what the CCG have given me, is autonomy in my life, and that's so important to people. So think about, it's not just about actually the outcome of the care, but it's about that process of empowerment as well. But yeah, thank you everyone so much. It's been great to have you all here, and we will upload this webinar online, so if people want to share it, just let me know. And if you can leave feedback on the link, you'll probably get an email in about an hour with the feedback link. If you could leave that feedback for us, that would be much appreciated. And thank you really for joining us. It's really appreciated.
Yeah, thanks everyone. It's been great to have such amazing turnout and great feedback as well from everyone, so thank you.
All right, take care everyone. Thank you.